Top Med Talk.
Top Med Talk is the broadcasting arm of EBPOM, Evidence-Based Perioperative Medicine. Last-minute tickets for EBPOM Ireland 2026 are available. Taking place from the 29th of September through to the 1st of October in the beautiful town of Dingle, Ireland, it's your chance to join us for an inspiring gathering of healthcare professionals, researchers and educators dedicated to advancing evidence-based practice through engaging keynote sessions and international collaboration. Check out ebpom.org. That's ebpom.org.
Hello, welcome to Top Med Talk. I'm Andy Cumpstey and I'm here at the American Society of Anaesthesiologists annual meeting 2025. That's Anaesthesiology 2025, which this year is in San Antonio, and I'm joined by my co-host, Mike Grocott.
Good afternoon, Andy.
It's a busy meeting.
It's been a very busy meeting, but this is one of the high points. We'll explain in a moment when our guest is introduced.
Absolutely. One of the best bits about the meeting for me has been the many research sessions. There's been lots of them talking about recent trial results. And it's a real pleasure that one of those speakers has agreed to come and join us and talk about his trial. So without further ado, Professor Paul Myles.
Good afternoon, Andy and Mike. Very pleased to be here.
Now, obviously, you're a friend of the podcast for some time, but for people that may have not listened to those episodes, and obviously they should have done, but could you please tell us a bit more about where you're working and your background before we get into the trial?
Yeah, okay. So I'm from Melbourne, Australia. I'm Director of Research in the Anaesthesiology department. I've had a long-term passion for large clinical trials, ideally multi-centered and international. We really aim to design up, get funded and conduct what we call pragmatic clinical trials, those that actually answer clinically important questions and help guide and improve our practice.
And you're saying this is normally done within the ANSCA Clinical Trials Network and other groups, is that right?
Yes, that's right. I mean, the best research is multidisciplinary and collaborative, and we really want to conduct our trials in a range of diverse healthcare settings so that the results are more generalizable and therefore can apply probably the most practices around the world.
And Paul, just before we get into the trial, we're going to talk about how does ANS manage itself in terms of topic selection and investigator selection? Because I think people looking from the outside will probably not appreciate how that all works.
Yes, I think the best science and research has always got a little bit of anarchy in it, but at the same time you do need some sort of structure, and we've learnt really through trial and error as much as anything, but a lot of goodwill, and people sort of propose or come up with potential research questions. They're sometimes debated or at least discussed. And then there's a sense of feedback that, look, there's enough different hospitals or centres involved in the ANSCA Clinical Trials Network that would like to join in that new endeavour. So we then put together a group of investigators that can really help sort of polish up the trial, sometimes do some pilot studies or a systematic review to give some background data to why we're doing the study and how big it needs to be, get the correct dose of whatever drug we're using and so on. And then we put all that together and apply for funding with our national funding agency, which in Australia is the National Health and Medical Research Council.
And I think it's fair to say you've got a pretty good track record over the years, not just getting that funding successfully, but also of helping to facilitate succession planning, other career researchers getting involved with those sort of trials and mentor them in that process.
Yeah, exactly right. And again, a lot of it has been trial and error, but there's now a lot of corporate memory. We have had a really good track record of doing these very large pragmatic trials. They get published in the very best journals, and we believe at least that they really do guide and inform practice. So that's what we're trying to do, and each trial we're trying to make better than the previous one and so on. But in that process, of course, we got to recognize that we need fresh ideas, fresh people. So we do have a very proactive peer support, mentorship culture within the group to always include at least several early or emerging clinical researchers into the team so that they can learn from what we've learned over decades, and then they can now really get themselves in a position to actually lead the trials of the future.
So I guess, without further ado, we should talk about the latest trial, which you were presenting yesterday. Do you want to give us the sort of the background summary of the ITACS trial and why you felt that was one of these important questions to answer?
Yeah, I guess acknowledging my own biases, I truly believe this is probably one of the most compelling and important trials we've ever done in the group. I think this should and will change practice around the world. The ITACS trial is an acronym for intravenous iron treatment for anaemia before cardiac surgery. So the rationale for the trial, which we published in the American Heart Journal in 2021, was that anaemia is very common in people coming for cardiac surgery. There's a whole lot of reasons for that. The incidence is typically around 30%. We know that anemia of itself is strongly associated with more complications, a longer hospital stay, and even mortality after cardiac surgery. And that probably holds true for most types of major surgery. Cardiac surgery is a nice model to test the concept and the hypothesis. We also know that anemia is associated with a greater need for blood transfusions. I think most of your listeners would appreciate that blood transfusions of themselves are also associated with more complications after surgery, a longer hospital stay, more mortality. So we've got this really difficult scenario in cardiac surgery where anemia is both common. We know blood transfusions, we're trying to avoid it as best we can, but because of the anemia, that really doubles the need for a risk of needing a blood transfusion. So there's now safe, relatively cheap intravenous iron preparations. They've been around now. They use safer versions for at least 5 or 10 years. And we thought we would design the ITACS trial to actually test the hypothesis that giving a single dose of intravenous iron, a dose of 1 gram, in the weeks before elective cardiac surgery could both increase the hemoglobin level and therefore partly treat the anemia, but more importantly, can lead to improved and faster recovery after surgery.
So Paul, I'm only asking this question because I've heard you explain this before and you do it really well.
I'll try again.
Well, why do we need to do the trial? Because you've just told us there's really clear observational data that anemia is bad. We know that if you give people iron, their hemoglobin goes up. I mean, what's the point of doing a randomized control trial in this setting?
Well, I guess to be harsh, or if you like, at least skeptical, I do know, and I think many people have probably heard of the fact that some anesthesiologists or anaesthetic departments are in fact setting up iron clinics or preoperative clinics to give IV iron for anemia before many types of surgery. But the data supporting that is very weak. And in fact, if you look at the best quality randomized controlled trials, they at this point in time wouldn't support that practice. And that practice of itself comes at some cost. There's a cost itself of running the clinic, the staff costs, of course, giving the therapy itself. But there's also the cost to the patient and their families. The patient often has to come back for an extra hospital visit. So I strongly believe that if we really are going to change practice, we need to base it on good quality evidence. We need consistency of practice really across the world. Why should it be different in one place versus another? And therefore we need good quality evidence. And that means a randomized controlled trial. Observational studies will often show you patterns or associations, but you cannot be sure that that's a causal relationship. We already know that blood transfusions are needed more often in those that are older, have comorbidities, poor heart function, they've got other risk factors, and maybe it's those factors and not the blood transfusion itself that is leading to the poor outcomes. So this is a great thing about a treatment that we can randomly assign to 2 groups. We can control that circumstance in such a way that we have genuine, reliable causal inference, and therefore we can reliably conclude that the intervention either did or did not work according to our hypothesis.
So we should talk about how you set the ITACS trial up and what the methodology looked like in this case.
So the first thing we wanted to do is, first of all, get good quality observational data to actually demonstrate and show that in our settings where the trial was going to be conducted, that in fact there was a sufficient proportion of patients that did in fact have anemia, that we could reliably identify them ahead of time before the surgery. And then, of course, we had to decide on what we thought was the optimal and effective dose that we should test in it. And that came largely just from straight literature review. We did a registry database analysis of over 10,000 patients and showed those associations I was talking about earlier. We didn't need to do a systematic review and meta-analysis because others had done that and demonstrated from small single-center studies that, in fact, there was at least a benefit in reducing red cell transfusions. And from all of that, we used the most commonly used dose in any studies that have been used up to that point in time, which was a 1 gram dose of intravenous iron. We do know that it's very effective at repleting iron stores in the body, and that's really equivalent to getting 1 year's oral tablet supplies of iron in under 30 minutes. So it's a very effective way of iron repletion. We do know it's very safe, but of course we built in some safety data endpoints into the trial as well. And then we had to decide on what was the ideal primary endpoint for the trial. And that's always a big question in any clinical trial design. And we felt that given the likely biological mechanisms of the benefit of intravenous iron in anemia is obviously in part to restore hemoglobin concentration. And at the same time, of course, ideally reduce the need for a blood transfusion. We know a patient with anemia after major surgery is very fatigued, has a slower recovery trajectory. They're at risk of ongoing complications that occur through the postoperative period, as well as fatigue and sleep disturbance, even in the months after surgery when they're back at home. So because of all those reasons, and we weren't sure which particular complication imminent, we chose to use the number of days alive and at home out to 90 days after surgery as our primary endpoint because it would do two things. First of all, of itself, it's a patient-centered outcome. Patients want to get home and be healthy again in their own home. They certainly want to avoid readmission back in hospital, and they certainly don't want to end up in a rehabilitation facility. But the other important thing of this metric, which I really like in perioperative medicine, is that it not only tells you something that's important for the patient and probably as a proxy of healthcare costs for the hospital systems, but it actually gives you a sense of the impact of any particular complication or combination of complications, rather than having, say, for instance, acute kidney injury or myocardial injury, or even a stroke or a myocardial infarction. In some patients, they're effectively asymptomatic and may not even know of it without blood tests and so on. But at the other end of the scale, of course, a massive ST elevation myocardial infarction or hemiplegic stroke is a disaster. But a stroke is labelled a stroke according to any of those ranges from pure asymptomatic through to overt hemiplegic stroke. And it's the same with myocardial infarction or pneumonia and many other complications. So the outcome metric of days alive and at home gives you the impact of such complications. So if they're bad enough to truly impact on hospital stay or risk of readmission or early death or any of these features, then in actual fact, you'll pick that up, whereas you might otherwise miss it.
So to summarize, we talked about you're going to give 1 gram of intravenous iron. You're looking for days alive at home 90 as your primary, but which patients were you testing this in and where were you conducting the study?
Well, as I mentioned in the acronym or the title of the trial, we were identifying patients with anemia. We used the World Health Organization definition, which for males is a hemoglobin concentration of less than 130 grams per litre. The current WHO guideline for females is 120, but we chose to use the same threshold, the 130 threshold for both sexes, in part because there's really no justification to have a sex differential definition of itself. We do know that cardiac surgical patients, through their workup, will just about always have a hemoglobin concentration done. So that's the point at which we identify the patients. So the next thing is to try and exclude out patients that have got anemia for other causes, in particular, say, megaloblastic anemia, various iron storage diseases and so on, where we don't believe intravenous iron would be of any benefit at all. We were wanting to and happy to include patients that had non-iron deficiency anemia, because there is anemia of chronic disease where there may well be reasonable iron stores of themselves, but it's not mobilized and converted into red cell production because of various biological mechanisms, which we might discuss. It's up to you. But we do know that intravenous iron, even in that setting, can have a benefit. So we just took patients of any type of anemia with the exclusions I mentioned, and literally they just had to be booked for surgery within 1 to 26 weeks into the future. We essentially aimed for the out-of-hospital elective surgery patients, the ones that were on the waiting list but at home and coming for surgery at some point in the future. We were certainly open and allowed patients who were inpatients and their booked surgery date was more than 1 week into the future. Now I'm a cardiac anesthesiologist, so it's very hard to know what cases are going to be done that week or the next week. And certainly in our hospital, that can change day to day. So it was very hard to reliably identify a scheduled patient. But we did allow it, and there were some in the trial where that was the case. And they're probably a group that would probably most benefit as long as their time between the administration of the IV iron and their actual day of surgery is ideally at least 2 weeks.
And sorry, before we go to the result, I've got one. It's a super geeky question. I suspect about 3 listeners will be interested in the result, but I think or the answer, but it's becoming more and more common, and therefore I think worth talking about in trials. Frequentist or Bayesian?
So this was done as a frequentist trial design, a conventional trial design. That's probably the safest design to use if you're applying for national funding, because everyone's familiar with that classic 2-arm parallel design. I personally am moving my research, our trials, into a Bayesian framework, but that's probably a conversation for another day.
And for some of those listeners who are not in that group of 2 or 3 that might just mention, do you want to just quickly summarize what you mean by that Bayesian design? Not in great depth, but just people understand what that term means or why it's different to the frequentist model.
Okay, so the frequentist model is simply you just make a comparison of the treatment groups at a single point in time, typically at the end of the trial. You may do an interim analysis or 2 through the conduct of a trial in a pre-planned way. In a Bayesian analysis, there is recurring, more frequent analyses of the data during the progress of the trial in such a way that you're protecting against false positive results or type 1 errors, but being able to stop the trial at a point in time when there's clearly demonstration of either benefit or harm. So it is an efficient trial design and you can get answers more quickly, but it requires very specialized statistical design and analysis and very careful thought in the trial protocol.
Perfect, thank you. And again, for listeners that may want more information about that, we've covered that topic in other Top Med Talk podcasts, so you can search that in our library. But let's move on and come back to ITACS. That was the frequentist design. And just before we talk about the results, I've got one last question to push you on a bit more about the inclusion criteria, because although I understand the definition was the World Health Organization definition of anemia, you could argue that's a relatively mild drop in hemoglobin that you were looking at. I mean, below 130, I don't think I see many elective, maybe some elective, but I don't see many patients in our intensive care units, for example, with hemoglobins anywhere near 130. And I see a lot of emergency surgery patients with hemoglobins near 190, 95.
That the incidence of anemia, or prevalence really of anemia in elective cardiac surgery, is about 30%. Most of those have got mild anemia. I mean, at least 80% of people have got mild anemia. It's less common to have what we would label as severe anemia, and that's typically defined with a hemoglobin concentration less than 100. So that is the case. Then in part, people who are in that bracket, nearly always surgery is deferred in a planned way, and they will usually receive iron therapy in any case. So we did recognize that most would be mild anemia, but this is where I think there's a false sense of confidence in perioperative clinicians, including anesthesiologists, in that mild anemia doesn't really matter that much. It's actually okay. What it is flagging is several things. First of all, your iron stores are typically very low. So although your body is compensated to an extent where there's a reasonable hemoglobin concentration, you really are on a precipice or a cliff's edge of quickly getting into a more severe iron depleted, severe anemic state. And this is exactly what happens in all types of very major surgery, especially cardiac surgery, where you will lose usually 0.5 to 1 litre of blood. So it's really in those days and weeks that follow the surgery that anemia gets fully exposed, and then you're really at high risk of the complications, what now would typically be severe anemia. I mean, the models of care that we've now got through the various colleges and so on about the care pathway in perioperative medicine of optimizing before surgery, correct detection and correction of anemia ought to be right at the top of the list of the things that we can identify and treat and put the patient into a better state. It's not just for the actual surgical procedure itself. It's really the days, weeks, and perhaps months afterwards. And that really comes into when we consider and discuss the actual final results. So we did a sample size calculation, again with our lovely statisticians, and we enrolled close to 1,000 patients in the trial. And we needed that sample size or that size trial to reliably identify at least a 1-day difference in terms of days alive at home out to 90 days after surgery. And at the same time, that will give us even extra power to look at differences in some of the serious complications, including the need for a red cell transfusion. So we did the trial, and amazingly, I was pleased to see at the end of the day, there was a statistically significant improvement in the number of days alive at home out to 90 days in the patients that received IV iron. Firstly, on the day of surgery, on the blood test results that we did when the patients were actually about to have their surgery, the hemoglobin level was better, only in a moderate degree, but enough to make the patients, I think, a little fitter to have the surgery. In terms of their iron stores as measured through the transferrin and the ferritin and the transferrin saturation, that they were markedly improved. So they were all highly significant results, and that really shouldn't be a surprise to anybody. We know intravenous iron is effective in treating at least iron deficiency anemia in other settings. There was a 1-day difference that was statistically significant, so there was an improvement in the IV iron group. The p-value for that was certainly less than 0.05, and therefore it is statistically significant, and I would argue clinically important. The other important findings that we identified was that there was a marked reduction in the need for red cell transfusions, both in the intraoperative period, in the first 30 days after surgery, and even out to the first 3 months after surgery. So it reduced red cell transfusions to really at least a moderate degree overall. We calculated on our data that for every 100 patients treated with intravenous iron, that you save 44 units of red cell in your blood service.
From a cost effectiveness point of view then, do you think that's where the cost saving is going to come in the reduction in transfusions? Because although a 1-day improvement in days live at home in the first 3 months is going to bring some cost saving, you could argue there's a cost with the iron infusion that may offset that slightly. It feels like the transfusion benefit would definitely be a cost saving as well.
Yeah, so I think you can do a back of the envelope calculation right now, and yes, you can clearly argue for cost effectiveness based purely on that. The 1-day improvement that we identified in our trial was mostly in the number of days that patients spent that were readmitted back to hospital. And that, of course, is a very costly thing, way more so than normal elective surgery. But we are doing a formal cost effectiveness analysis with a health economist. Those data are all being analysed now. We collected a lot of extra care resource data for all the patients enrolled in Australia, which was the majority of the study population. And that's all being analysed at the moment, and there will be a publication, we hope, in the next 6 months.
Exciting.
I mean, the difference in the hemoglobins immediately post-op, you said, was small but statistically significant.
Yes.
But you had, in some cases, a relatively short window pre-op for the treatment to take effect. Did you get any later hemoglobin measurements?
We measured their highest and lowest hemoglobin out to 30 days after surgery. That's the last measurement we had because patients obviously discharged home and most, of course, weren't coming back to hospital for any particular reason. The hemoglobin level is really a tip of the iceberg in terms of iron biology. So although there was only it was a roughly 0.4, 0.5 or 5 grams per litre difference. But what it is manifesting is the very complete repletion of iron stores in the body. So as I mentioned earlier in our conversation, the real period of concern is after all the blood loss after surgery, in those days, weeks after surgery, when the bone marrow response is to upregulate red cell production. There's now a full bank account really of iron ready to go to be brought into that new hemoglobin synthesis.
And you've got a little bit of confounded by indication because the transfusions are aiming for a target.
Yes.
So any signal would be somewhat obscured, and actually the money shot, if you like, is the fact that he had reduced transfusions in the iron group.
That's exactly right. And of course, the cost of an intravenous iron injection or infusion is way less than the cost of a single unit of red cell.
Any practical challenge? You sometimes hear the pushback of, it's really difficult to get people in to do this. And in the conduct of the study, it was reasonably straightforward to administer the intervention.
Yeah, so again, we allowed sites around the world. There were 33 hospitals across 10 different countries. So again, it was a range of healthcare settings and so on in it. In our case, at our hospital, we identified the patients. We had their hemoglobin response before they came into the clinic for the pre-admission workup by our team, the anesthesiology team, and they're also often seeing the surgical team on the same day. So we would actually consent them and treat them at that time, on that day. So there was no extra visits involved at all. And that was most often the case across the 33 hospitals. There was no extra hospital visits required. It was done in the scheduling of the patient who were coming in for either outpatient or other visits to the hospital in any case. Now, the other bit that's probably important in this relates to that burden of if they do need to come back or if you do need to set up a specialised iron clinic. Up until this point in time, and certainly our trial result, there really wasn't sufficient data and therefore I think even motivation to actually, or even making a cost argument, to actually have that conversation with the patient, say, look, theoretically we think this can improve your outcome after surgery. We've now got a situation where we think we've got hard data, we've got evidence that in fact it is well worthwhile you coming in having that injection. And that's the same, I think, in conversations with our surgical colleagues and others who might be caring for the elective surgery, cardiac surgery patients. And that, I think, would include family practitioners or general practitioners, even out to the community. They've got patients, obviously, they know their patients going off for cardiac surgery at some point in the next few months. They're in the best position to actually counsel and treat the anemia before surgery. And that, of course, isn't happening at the moment. It hasn't been happening, but it probably needs to happen now.
So, brilliant trial, great result. As you say, it's going to be practice changing. I know the evidence in general surgery is negative.
Yes.
So I was involved in the PREVENT trial. I suspect you were too, and there was no demonstration of benefit. However, despite being a enthusiastic clinical trialist and all about evidence-based medicine, we have an anemia clinic in Southampton, and we've shown a more than halving of transfusion requirements just in practice in our general surgical patients. So my question is, are you going to revisit that study as well?
I would love someone else to revisit that study. I think I think the results for me are quite compelling and I think will certainly change our practice at our hospital.
Cardiac surgery.
In cardiac surgery. I think it is rational and valid to extrapolate to other areas of major surgery where expected blood loss exceeds 500 mils. That would be my kind of thinking around this subject. However, I still think a large randomized controlled trial is actually needed because some people will be convinced, as you say, some people have got clinics and others haven't in the non-cardiac surgery setting. I would like to know the real answer, the true answer, get towards truth. Such that all those places that are a bit more skeptical or are not offering such a service at the moment could be brought on board. Or if in fact it was a truly negative result that was reliable, then in fact to stop the practice in settings where it's simply not effective.
I mean, I'd love to see that, and I'd also love to see you and Toby Richards on the same couch. We can come back to that.
We're probably running out of time. I was going to ask you a very similar question, but I think extrapolating it to non-cardiac surgery with the estimated blood size 500 mils, but there are big differences between non-cardiac and cardiac surgery, and the use of bypass, that all the other pleiotropic effects the iron has that may be cardiac specific or cardiac muscle specific, mitochondrial effects, which we haven't got time to go into in depth, but I think it's worth highlighting those for listeners, that it's probably not quite as simple as we just take this one trial result and put it into a different surgical population.
I completely agree with that. That's completely true. And I think we have to retain that equipoise and support any such good quality trial that's may be developed in the near future, so that we can get the answers quick as possible.
I guess Andy and I need to emphasise to whoever's listening that they haven't stepped into a time warp, because we're going to embargo this conversation. You're not yet published, so we don't know quite when this podcast will come out. So when it comes out and somebody says, I'm at Anaesthesiology 2025, there's a good reason.
Yeah. Fantastic. Well, thank you very much for joining us, Paul. Thank you for agreeing to come and chat about these results ahead of publication. Great to have you back on the couch.
Thank you. It's a pleasure.
As always, you can find this podcast and all our others on our website on topmedtalk.com. You can find us on social media. We're on all the main platforms. If you do go onto there, including YouTube, please hit like, please hit subscribe. It really does make a difference to us at this end. We need to thank our sponsors, as always. So this year, that's BD, formerly Edward Life Sciences, now BD Advanced Patient Care Monitoring, and GE Healthcare. And of course, a huge thank you to the American Society of Anaesthesiologists for giving us this fantastic booth at this meeting. And we'll see you again next time.
Top Med Talk.
Top Med Talk is the broadcasting arm of EBPOM, evidence-based perioperative medicine. Last-minute tickets for EBPOM Ireland 2026 are available. Taking place from the 29th of September through to the 1st of October in the beautiful town of Dingle, Ireland, it's your chance to join us for an inspiring gathering of healthcare professionals, researchers and educators dedicated to advancing evidence-based practice through engaging keynote sessions and international collaboration. Check out ebpom.org. That's ebpom.org.